Thank you, ma'am, for those kind words. Respected chairperson, the distinguished doctors present here, very good afternoon to all of you. And at the outset, I must thank RSSDI and Dr. Bansi Sabu sir for giving this opportunity. And Dr. Pramod Gandhi sir actually told what is the role of DPP4 inhibitor in managing type 2 diabetes. They are one of the good drugs. That means they don't produce any hypoglycemia, they don't produce weight gain, they are almost inert, they don't produce any adverse events. So without wasting much time on DPP4 inhibitor, I'll just highlight one molecule which is also there in our market, a relatively newer DPP4 inhibitor, and that is Evogliptin. And I'll tell what are the evidences in support of this newer DPP4 inhibitor. So coming to the molecule proper, it's Evogliptin is a selective, potent and reversible inhibitor of DPP4, extensively studied in efficacy and safety, and I will be highlighting what are the studies which has been done. And it is approved in many Asian countries and to some extent Africa also, and it was approved in 2018 August by the Drug Controller General of India for use in patients with diabetes. And the current indication, it can be used as a monotherapy in patients with type 2 diabetes or in combination with metformin. And the doses it's a OD dose, and it's 5 milligram once in a day. And if we see the binding sites of the DPP4 inhibitor, this Evogliptin, you can see that this is the DPP4 enzyme. We have S1, S2, S1 dash, S2 dash, and the S2 extensive. And the DPP4 inhibitor which binds to the S1, S2, and the S2 extensive is Evogliptin, Teneligliptin, Sitagliptin, and Evogliptin is one of them. And it binds to these sites, and the binding is mostly non-covalent binding. Coming to the comparison of selectivity of DPP4 inhibitor, that also Dr. Pramod Gandhi sir has shown in terms of the different DPP4 inhibitor like Sitagliptin, Vildagliptin, Saxagliptin, Allogliptin, and now the Evogliptin. You can see that the IC50 is the lowest with this Evogliptin, and compared to DPP8 and DPP9, the DPP4 sensitivity is quite good in terms of more than 6,000 selectivity for DPP4 inhibition. And we know that once the selectivity increases for DPP4 in comparison to DPP8 and DPP9, some of the adverse events are actually reduced. The pharmacokinetic of this relatively newer molecule is that it reaches its plasma concentration within 3 to 5 hours, and the terminal elimination half-life is long. It's around 32 to 39.8 hours, and it reaches its steady state almost after 3 days. But there was always a concern about accumulation of this drug because the half-life is more. But once they found the pharmacokinetic accumulation index, it was nearly normal, so it doesn't accumulate even if given once in a day. And one of the best part of it is that unlike some other DPP4 inhibitors, it is not an inducer of cytochrome P450 or neither an inhibitor of this cytochrome pathway, so it doesn't interfere with other concomitant drugs. Only a fraction is excreted unchanged in urine. Major excretion is through the liver and partly through the kidney, and so no dose adjustment is required because urinary excretion is not the major pathway of elimination. Even the dose and administration adjustment is not needed in patients with mild to moderate hepatic impairment, and there are studies for PK data for that also. The favorable pharmacokinetics, if we compare the other gliptins, then we can see that Evogliptin, it's given once in a day, and it's hepatic and lesser by the renal route of excretion. Now, what about the evidences? Because we live in a world of evidence-based medicine, so each molecule has to show its evidence in not only the randomized control trials but also real-world evidence. And these are all the landscape of evidences which has been done with Evogliptin, and there are phase 1 dose finding studies, and then there are phase 2 studies, phase 3 studies, and then there are post-marketing trials also. So coming to the clinical evidences with Evogliptin as a monotherapy, we have good data on Evogliptin Monotherapy in patients with type 2 diabetes who are drug naive versus placebo, and that was a Korean data. And if you see the blue boxes, that is, I'm highlighting the monotherapy comparison. They have actually, the Brazilian trial or the bridging study, they have actually compared the Evogliptin to that of the standard DP4 inhibitor like sitagliptin. And another Evergreen study, they have compared Evogliptin versus another standard DP4 inhibitor like linagliptin, and that was a CGM based studies. The other 3 trials are actually a combination study over and above metformin therapy. So this is the international study of Evogliptin monotherapy in patients with type 2 diabetes, and though the study population was not that large, but 5 milligram of Evogliptin in comparison to placebo, it could show the reduction of HbA1c from 7.2 to 6.97. It was 0.23%, but it was significant. But again, the baseline A1c was not that high, so it didn't show that much reduction of HbA1c. But in the subgroup analysis, when they saw that the higher the HbA1c, the better is the reduction, like almost 0.67% reduction of A1c once the group is more than 7.5% A1c. In the Brazilian study, they have compared Evogliptin versus sitagliptin, and this was necessary because to find about the non-inferiority. And what they found was that different doses of Evogliptin they have given, and in comparison they have given sitagliptin 100 also. And in comparison to sitagliptin, if you see the right side graphs, the sitagliptin 100 versus Evogliptin 5 milligram, the reduction of the HbA1c is almost similar, to the tune of around 1.30. So at least this molecule has proven non-inferiority to that of the sitagliptin. The Evergreen study is actually a CGM based study where they have compared again in monotherapy after lifestyle modification. One arm they have given Evogliptin 5 milligram, and in the other arm they have given linagliptin 5 milligram, and they did CGMS at the beginning and at the end of the 12 weeks of the therapy and 24 weeks at the end of the therapy. So what they found was that the change in A1c from baseline to week 12 in Evogliptin was almost like 0.85%, and in comparison to linagliptin, which is 0.75%. But there was that was a proof of non-inferiority only. That means the reduction of the A1c with Evogliptin is almost comparable to that of the linagliptin. And the percentage of patient who could achieve an A1c of less than 7% at 12 weeks is also comparable between Evogliptin and linagliptin. And as I have told, it was a CGMS based study in the initial part and at the end of 12 weeks, and they found that the mean amplitude of glucose excursion with the CGM, that was numerically better with Evogliptin, but it didn't achieve statistical significance, so we cannot comment on that. And the standard deviation of the glucose was almost similar. And proportion of time in glucose range with Evogliptin at the beginning or at the initiation of the study, it was 40.44% in time in range, which has improved to 59.22% at the end of the 24 weeks. So just the conclusion of that study was that it was non-inferior to that of the linagliptin even in the CGM study. Now, renal dysfunction is very important because we all know that DP4 inhibitor almost they are safe in renal failure, and so also the Evogliptin has also proven its safety in renal failure. They have taken patients with mild to severe renal dysfunction, and they found the Cmax and the area under the curve in mild and moderate renal insufficiency and severe renal insufficiency, and they didn't find any changes in the or the dose accumulation or any adverse event. So concentration was found safe in phase 1 multi-dose study also, and for all practical purposes the drug was found safe in all grades of kidney function, but there was no good data to support its use in end stage renal disease or the people with dialysis, so should not be used in those group of patients. Similarly, the pharmacokinetic and safety property in patients with hepatic impairment has also been studied, and it also has shown that Evogliptin can be used in mild to moderate hepatic impairment also. Now, cardiovascular safety is always a concern because we have so many cardiovascular outcome trials with DP4, other DP4, and also with SGLT2 inhibitor. Though there is no dedicated cardiovascular outcome trial for Evogliptin, but they have taken a Korean registry where a big chunk of patients, like 3 lakh patients who are on metformin, have been shifted to a second line of therapy with either a metformin with glimepiride or metformin with DP4 inhibitor and metformin with SGLT2 inhibitor. And in the DP4 inhibitor group, they have also used Evogliptin almost in 3000 patients. And what they found was that in comparison to glimepiride, where they have taken as the standard, the DP4 inhibitor that includes the use of Evogliptin also were associated with, in fact, a decreased risk of cardiovascular events, and with a hazard ratio of 0.87 with a p-value which was significant. So the use of Evogliptin either decreased the risk of CVD or had no association with it compared to other ingredients of DP4 inhibitor or SGLT2 inhibitors. So that was all about the Evogliptin as monotherapy. Now the combination is also available, Evogliptin and Metformin, and there are various countries where it is available, and there are studies of use of Evogliptin versus sitagliptin over and above metformin therapy, and that was a Korean study. Then there was Evolution India study, that was a Indian regulatory study, and the third one is an Russian study. And also there are some FDC preparation of Evogliptin plus metformin formulation, and the PK study was also seen. The study in Indian population, they found that in comparison to metformin, sitagliptin, metformin, Evogliptin, the reduction of HbA1c was almost similar to the tune of 0.55% or 0.48%, which shows the non-inferiority of metformin with sitagliptin versus metformin with Evogliptin. And safety of Evogliptin, they didn't find any increased in the adverse event with Evogliptin, and it was quite safe, and the hypoglycemia incidences were not high also. Some of the latest Indian data from Evogliptin with metformin, and this is one of the poster which was published, which was there in last year RSSDI 2020. Though the population was less, around 20 patients, but in contrast to the usual therapy of Evogliptin with metformin or plain Evogliptin, they have actually used in the real world setup all kind of combination, even with glimepiride, metformin or SGLT2 inhibitor with Evogliptin, and they found that in this real world evidences, the reduction of A1C was quite significant to the tune of 0.9 to 1.45%. They've also done a CGM study with the Evogliptin in the real world setup, and they found the mean blood glucose level was lower, and the time in range has significantly improved with the use of Evogliptin. Then there was study of Evogliptin use in patients who are on insulin, and there also two important things came out, that the A1C reduction was more once you added metformin, Evogliptin with insulin, and the insulin dose requirement has also significantly reduced with the use of metformin, Evogliptin with insulin. Now this is an active post-marketing surveillance of FDC of Evogliptin plus metformin hydrochloride, and it was shown in the poster in this RSSDI 2021. They have taken 300 Indian patients from 6 centers, and it's a duration of 24 weeks, and they've used a FDC of metformin with Evogliptin, and they found that there was a significant reduction of the A1C at the end of 12 weeks and at the end of 24 weeks, and change of A1C was to the tune of 0.6% to 1%. The FBG and PPG reduction was also significant at the end of 24 weeks, and the conclusion was that FDC of Evogliptin 5 mg plus metformin sustained release 1000 mg in a bilayered tablet effectively reduces the fasting PP and also the A1C, and there was no significant adverse event associated with that. So summarizing and coming to the end of the presentation, Evogliptin is truly once a day due to its longest half-life of 32 hours, established renal, hepatic safety and CV safety, And as per the Evergreen Study, A1C reduction was proven to be non-inferior versus linagliptin. And the Evolution India study has shown there was a head-to-head comparison of metformin with sitagliptin versus metformin with evogliptin, which is non-inferior. And evogliptin metformin FDC formulation provides better compliance, convenient in administration, and a strong OD dose rationale. So with that, I'll end. Thank you for the patient hearing.